Hello, and welcome to the international webinar on innovations and excellence in palliative care education. My name is Melvin Bell, and I'm the founder and CEO of Focus Games, and we're delighted to have you join us for this important event organized by Pallium India and Focus Games. This webinar brings together leading experts, educators, and healthcare professionals from around the world to explore the latest advancements in palliative care education and practice. Palliative medicine is more than just managing symptoms. It's about delivering compassionate, patient-centered care that enhances the quality of life for those facing serious illness. As the field evolves, so must our approaches to education. Traditional education methods, while essential, can be complemented by innovative learning strategies, such as game-based education, to improve understanding, empathy, and the application of best practice. Focus Games is a UK and India-based company specializing in serious games and game-based learning. We develop interactive educational tools designed to enhance healthcare training. Our work emphasizes the power of engaging experiential learning to improve knowledge, retention, and practical application of healthcare settings. Today, we will discuss key topics, including effective symptom control, quality end-of-life care, and the role of game-based learning in medical education. Through these discussions, we hope to inspire new perspectives and equip you with valuable insights to enhance your practice and teaching. Thank you for being part of this journey towards excellence in palliative care education. We look forward to an engaging and insightful session together. The webinar is being recorded and will be made available to you after today's screening. Please use the chat to raise any questions, and we'll take a few minutes at the end of each speaker to address questions. And again, at the end of the webinar, we'll have a final wrap-up session for questions. I would now like to invite our first speaker, Dr. Sreedevi Warrier, Head of Education and Skills Building at Pallium India. Having a decade of experience as being a clinician, a teacher, and a mentor, Dr. Sreedevi is actively nurturing her passion for spreading the worthiness of palliative care across the country. She has done her Masters in Palliative Medicine from Cardiff University, Wales, and is an honorary tutor with them. She has worked as a senior clinical research fellow in the collaborative project with UCSF and Manipur University on intersectionality in HIV, cancer, and palliative care. She has won prestigious Commonwealth scholarship and spoken at various conferences and national faculties for many training programs in India. So I'd like to welcome Dr. Sreedevi, and I'll pass over to you.
Thank you, Melvin, and thank you all the participants who are in this broadcast for joining us this evening. So, Melvin, I think you can start sharing. Thank you. So I'll talk a little bit about the organization that I represent and about the educational activities, probably sharing a little bit about what has worked well, so people who are aspiring to be the educationists in this country, that can be shared, or I'm happy to listen their feedbacks to. Next slide, please. So I represent Pallium India. So a little bit about the organization. It is a 21-year-old organization in the southern part of the country. We are situated in the southernmost tip of India, in Kerala, and it is founded by a person called Dr. M.R. Rajgopal, who is a Padma Shri awardee, and he's also always referred as the father of palliative care in the country. So we work in a model called DEF, which is demonstrate, educate, and facilitate. We are also a WHO collaborating center and a member of United Nations ECOSOC. Next slide, please. So I'll just touch upon why we are doing what we are doing, because I'm sure there are participants from across the globe. But in India, what happens when we have a serious health-related suffering diagnosis, a life-limiting illness diagnosis? For example, you meet with an accident or you have a stroke or you have a diagnosis of cancer, we start paying from our pocket. We start selling things. We start selling our homes, our children's education. We may not be able to go for a job. The government doesn't pay for most of the things that we have to take care of. So this is a study done by the Lancet Commission in 2018 on healthcare expenditure among 122 countries. And it says that in our country, the out-of-pocket health expenditure pushes 55 million Indians below the poverty line. And we see that day in and day out. So here, knowing the pharmacology of medications alone may not work in providing palliative care because people lose their life once they are diagnosed with a life-limiting situation. Next slide, please. This is our definition of palliative care for people to understand it very well from layman to doctors, because in India, the perspective of palliative care is very different from other parts of the country or other parts of the world, especially from global north. We have our own definition of palliative care because we don't restrict palliative care to just cancer. It is applicable to any serious health-related suffering. And as many people believe, it is not just end-of-life care. We're actually living the full life till the life is over, till the last minute, and continue supporting the family members after that. So this picture on the right depicts what exactly we mean by palliative care, including a lot of community support, giving strength to the root to grow downwards so that the plant remains healthy as much as possible. Next slide, please. So what do we work for? This is the vision of our organization: stop needless health-related suffering so that people wake up to life, love, and hope. Next slide, please. As I mentioned in the beginning, we work on a demonstrate, educate, and facilitate model. In the demonstrating model, demonstrate part, we have inpatient, outpatient, and home-based care, telehealth, and rehab. In this, I would focus more on home-based care because that is a unique model that works in this part of the country. Next slide. So why do we need home care and what is the role of community in delivering home-based care? Because people live in their homes, they want to be in their homes, even if they are diagnosed with health-related suffering. So we help with, we collaborate with the community nearby. The community help us with food assistance, vocational rehab. As I mentioned, people lose everything when they are diagnosed with a life-limiting condition. It is not just the illness that we are dealing with, but it is about the patient, the family, and their life ahead that we are dealing with. So we provide them with education support, their children, so that children doesn't have to stop going to school because they don't have money to pay the fees. We help with the aids and assistive devices so that they can be mobile as much as possible. Many a times there are a lot of government schemes, but people do not know how to apply, where to apply, and how to take it ahead. So we help to link them with the government schemes, which is already existing. Many a times, most of our homes are not barrier friendly. Once someone is on wheelchair, then probably the roads may not be accessible. The toilets are not accessible by and large in our country. So we help with home modification so that they can live their life with dignity. So dignity is a broader term that I want to enlighten here. So why I'm giving this background is that all the training programs that we do is based on this particular philosophy of palliative care. Next slide, please. So this is the distance of home care team. The home care team has traveled an equivalent of revolving around Earth 4 times to provide services for our patients. And this is the number of the kilometers that we travel every year to reach out to patients in need. Next slide, please. This is the part where I take care of, which is the educate, in demonstrate, educate, facilitate model. We do run in-person and virtual courses, not just for doctors, but also for the interdisciplinary team. So our idea is to empower there is no point in training just a doctor and send them back to the setting. We want the team to be empowered to deliver quality palliative care in their own setting, including volunteers. Next slide. The third part is facilitate. So you have a demonstration model in Kerala. You educate people how to replicate or modify that model in their setting, and it doesn't stop there. We facilitate to help them to start palliative care services in their setting. They might be from an NGO, they might be from a corporate sector. We link them to the government, we link them to the nearby NGOs, we link them to the people in the community so that they can start their own palliative care services, which will improve access to opioids, which is a major crisis in our country. Next slide, please. I'm not going to read all these points, but this is what we are, and this is the foundation where we are working on. Next slide, please. A little bit about the impact that we have created. We have reached out to 27,000 patients, 81,000 family members, and we have provided rehab support to many 10,000s. And through our education programs, we have reached out to around more than 2 million people through the doctors and nurses that we train through various training programs. Next slide, please. This is what we are aiming for. According to the Lancet Commission report, which was published about this serious health-related suffering in low middle-income countries, it is estimated that we have around 10 million people in suffering in any low middle-income country. So we want to reach out to those 10 million by 2030. That is what we are all working towards. Next slide. You can put the next picture also. Yeah, so I just want to compare the India as a country. We are holding a lot of countries in our country in terms of population. So probably UK will be as big as the Madhya Pradesh in India. And we have Italy, Ukraine, Brazil, and everything is occupied in 1/3 of the landscape of US probably. But on the right-hand side, you have a map in terms of opioid access. You can barely see our country. That is where we stand when we come to the pain management, and the work that Pallium do in terms of education is to make that map bigger so that we are visible in the map of opioid access for pain management. Next slide, please. This is where the education stands. People ask, what are you doing in your organization? Why don't you take care of patients in the community? But with a larger vision to get a public health policy into place, education plays a major role because unfortunately, since a few years back, our medical and nursing education doesn't touch upon pain management and palliative care. So we need to have different programs to empower them to provide palliative care. Next slide, please. So these are the 3 modes of delivery. We have residential, online, and on-site programs. Next slide. So residential program, we do it in Kerala, where people from different parts of the country, we get people from other countries also. They stay here for 6 weeks. We can go to the next slide, where I have shown the details. We have 6-week certificate course program for doctors, nurses, and there are 10 days program. We also have a 1-year fellowship program, which is called Global Fellowship in Palliative Medicine. We have collaboration with the Queen's University, Canada for this one particular program in the end. We are on the 3rd year of Global Fellowship program. All the other programs we have started since 2008, where the education programs were very, very less in this country. Next slide. So what do we do when they come here? See, people, we are talking about adult learning. They don't want textbook knowledge. When they come here, they get a little bit of theory session, but 70% of the time they're spending with patients and families in a home care setting, in a community setting, in telehealth, inpatient and outpatient. So it's basically an experiential learning. They go back with a lot of experience and not just knowledge, but skills, because they get to do things, get to see things that they have heard or they have seen somewhere. So here they come and experience those for 6 weeks, which is a good enough time for them to integrate that into their learning system. Next slide. This is one of the screenshots from our virtual training program. Next. We started a virtual training program in 2016 in collaboration with Project ECHO. It is extension for community health outcomes based in New Mexico. So 2016 in India, the virtual training program in palliative care was totally unheard of because we believe a lot in being in person, understanding from the body language. The touch was very important. Virtual training program doesn't give those values. So we were a little skeptical when we started, but we are moving ahead a lot with that virtual training program. Next slide. So what are the training, who all we cater to through our training programs? This is a nutshell of people who attend the training programs. We have doctors, nurses, physiotherapists, nursing students, medical students. We also focus on specialists, because if you want to integrate palliative care in oncology, then oncologists have to be aware of palliative care. You want to treat terminal breathlessness or COPD, the symptom management, then you have to get hold of pulmonologists to make them prescribe certain medications. Now we are focusing more on geriatricians and ICU physicians. In emergency medicine, now palliative care is a very hot topic probably. So we get a request from the ICU physicians to make them trained in palliative care so that they can have those conversations with the patients and families and talk about advanced care planning and other things. Yes, we depend a lot on community for taking care of patients because they are at their home, we are in a hospital. The volunteers form the link between us and the patients. So we train volunteers and students as a part of our community participation. And we also have certain training programs aimed towards palliative care beneficiaries because they have a lived experience. They are the best advocates for changing policies, changing programs in the country. So we train them to make them better advocates so that we can have stronger advocacy backup. Next slide. I'm not going to the details. This is how typically our classroom session looks like. We start with the didactic, and then every session will have mandatorily a story, patient story based discussion. We can call it case discussion, but we don't like to call patient's case. So we made it patient story discussion because essentially we are discussing their story than a medical case. Next slide, please. A few testimonials I wrote because these are people working, one from Uganda, which was a community healthcare nurse, and one professor. So I wanted to show that, I mean, it is not covered in any of their education programs in the past. They have not learned in the undergraduate or in the postgraduate time. Now they are learning it as a different specialty altogether. So that is a situation in our country. Just to show how people enjoy the training program and how they change their practice after the training program. Next slide. We just did an evaluation in the past whether we are contributing something to enhance their knowledge. I'm so sorry that some of the texts are not readable, but we've asked whether they have, how confident they are in managing pain and symptoms and end-of-life care, having conversations with patient, and we got a overwhelming response on how it has improved their confidence level in managing the symptoms and pain before and after the course. Next slide. I'll just touch upon a little bit about, I'll not take too much time, but about some of the programs that we take here. One is the Global Fellowship Program. So this is a hybrid program. People can attend certain sessions online, but with a lot of hands-on training program. We have people from, although we've aimed to train people from India, we get a lot of applications from abroad. So we have a lot of international fellows joining this coming year also. Next slide. I think this is the first batch of global fellows. This is one of its kind in the country. And through our training programs, we have so far completed 173. That's okay, Melvin. Next slide. This was just a picture. We have done 173 training programs, reaching out to 28 states and 6 union territories. We have reached out to 21 countries, and we have touched more than around 3 million people in suffering in India through the doctors and nurses that we train our training programs. Next slide. This is another program. People who do not have time to attend the live programs, they have self-directed learning program. They can do in their own pace. We are offering this program for medical interns also, because that is how they can learn palliative care along with their internship, along with their beginning of their clinical practice. It has 33 modules, and they can do it in their own pace. Next slide. This is another program which has self-directed learning, but also has live discussions, case-based discussions, and video lectures into it. So they can have a face-to-face session whenever they are in doubt, and they can have self-directed learning modules whenever they have time. Next slide. This is another new program which we started 2 years back. In India, the palliative care is integrated into the curriculum only a few years back. So it is integrated into the curriculum, but faculty members are not trained to deliver the subject. So we are empowering the faculty members in the country so that they can teach the students. And we are talking about 800 medical colleges and more than 2,000 nursing colleges in the country. So we train the faculty members through undergraduate medical education and nursing education program. We have developed modules specifically for the faculty members in the teaching institutions. I think next is the last slide, probably. A few learnings, the education programs, we are talking about adult learning. So we are not talking about education. We are talking about exchanging ideas. They are the experts in their field. They will have immense experience. Me sitting in Kerala, the scenario will be very different from where Dr. Dylan is practicing or Melvin is living. It is very different. So it is about mutual learning, understanding from each other. Case-based discussions have always worked. People don't want didactic. They can read from the book. They want, okay, come up with a presentation, come up with a real scenario and tell me what you have done in that. How did you manage that symptom? So people find interest in bringing in cases or listening to case-based discussions in the sessions. Patient stories always have better impact. You talk about real patient stories and what you felt. There are moments of failures, like where I didn't communicate well. The patient was angry. I mean, that's what people want to learn. They don't want to learn about the ideal situation. Like, I was also stuck. I was also helpless. So stories, real life stories, always has a major impact in training programs. It is important to ensure quality at various checkpoints, because nowadays there are a lot of online training programs happening. People just come, log in, they just go somewhere and then they ask, okay, I have done the training program. That doesn't happen with any of our training programs. We are very particular about the attendance, the videos on. There are checkpoints where we check the knowledge by means of assessments. We ask questions related to the lecture, I mean, which they can't read from textbooks probably. So they have to go back and listen to the lecture, then only they'll be able to pass the assignment. Only when they pass the assignment, they'll be able to get certified. So having checkpoints are very, very, very important. Otherwise, people just log in, they just go and then ask for certificate. That may not work well. There should be enough motivation from our side for the learner as well as for the faculty. I mean, the faculty members, we have a huge faculty pool, but it is always good to give feedback, good constructive feedbacks, negative feedbacks, so that there's always an interaction between you both. And if the learner has completed a course, suppose he has treated pain for a particular patient, we ask them to share their story. That is put up there. Okay, this person has done a good job. So that gives motivation to them as well as the fellow learners. So it is always good to have that engagement. We're still in touch with all the trainees, all these thousands and 10,000s of trainees. They can ask questions any point of time. Some of us will be available in the WhatsApp groups. So I will stop my speech there. If anyone is interested to know more about the training programs, you can check on the website. We have a training page where you have mentioned the foundation level training programs, although we have many more, which we'll be notifying in the social medias, LinkedIn, Twitter. You can find us everywhere in Pallium India. If you want to write to us, you can write to education@palliumindia.org. We will guide you to the right course that you are looking for. Thank you.
Lovely. Thank you, Dr. Sreedevi. And it's great to see the work that you're doing there in India and across the country. So next speaker is Dr. Claire Atkinson, and she's the lead consultant in palliative and supportive care in the University of Wales, Cardiff in the UK. She has a special interest in improving service access for those with life-limiting non-cancer diagnosis. She designed the bed race palliative care board game during the COVID-19 pandemic in an effort to make palliative care education more interesting and fun. Our talk this morning will explore the elements of a good death and how these may affect our care delivery for those at their end of life.
Hello everybody, good evening. So I'm going to present a little bit about a good death. So I've actually worked in palliative care for about almost 30 years, and I've never actually presented on what a good death is. So I present about lots of things, often about non-cancer palliative care, but this is the first time that I've put together a presentation about this. So I called it The Good, the Bad and the Ugly. That's actually a reference to a 1966 film, a Clint Eastwood Western, in fact. I think there's probably quite a lot of shootouts of deaths in that film. But palliative care, as we all know, is about actually anticipated death, and how we can perhaps make this good as opposed to poor, regardless of where we are in the world. Advance slide, please. So what is a good death? When I first worked in a hospice back in mid-1990s, all patients were laid out with a small bunch of flowers on their chest, and what appeared to be the perfect end to life. But as we all know, death is actually as a process rather than a moment. Next slide. So I asked a friend of mine what she thought. She's a very senior psychologist, and I thought, I'm just going to take a completely separate view, someone who doesn't work in palliative care, and ask her, someone who lives in the UK, what she would like at end of life. And she said to me, I want to be in some serene hospice with beautiful gardens and a massive French-style bedroom. So in my mind, I saw this incredible building that she wanted to die in. And this incredible bed. So we can have some quite idealized views about how we would like our death to be, and we don't all in any shape or form have those sorts of opportunities or choices. So being a doctor, I instead turned to the literature, and I found a really lovely paper published in the Lancet, very well respected journal. Quite recent, 2023, a beautiful meta-systematic review. A systematic review of systematic reviews. What could be better? They'd taken a huge number of studies, and they just set them down to 13 of the highest standard. It covered 407 papers, and they had synthesized it down to 11 conditions which they considered to be required for a good death. So this seemed like quite a good place to be looking. And the things that they had established in order of importance was, number one, relief from physical pain and other symptoms. Well, I don't think any of us would argue with that. Number two, effective communication and relationships with healthcare providers. Seems pretty reasonable to me. Number three, autonomy with regards to treatment-related decision-making. This is a really important one, which I'm going to go back to in a minute. Number four, not prolonging life unnecessarily. Number five, dying in preferred place. Obviously, we can all have a preferred place. We don't always get what we want. Next slide. Awareness of the deep significance of what is happening. Emotional support from loved ones. Not being a burden on anyone. Performance of cultural, religious or other spiritual rituals. Relief from emotional distress or other psychological suffering. And the observant amongst you will notice that number 11 is missing. I'll go back to that in a minute. So what's really important from the previous slide to note is that all of those literature reviews had a massive preponderance from high-income countries. 7 systematic reviews from America, 1 from Canada, 1 from the UK, 1 from New Zealand, and there was very minimal representation from low to middle income countries. So although palliative care is the birthplace, UK is the birthplace of palliative care, we can see that the literature is hugely biased around this definition of a good death. So I decided to keep looking a little bit further. Next slide. So instead I went to a publication in looking in the journalistic realms, and The Economist, which again, a very well-respected publication, had devised in 2010 something called the Quality of Death Index. So I thought, well, this looked like it might be something that was a good thing to follow. They had devised and constructed through an Economist Intelligence Unit, the EIU, in 2010, which sounded pretty official. They built this index using official data, existing research for each country, and interviewing palliative care experts from around the world. Seems pretty robust, doesn't it? And they'd evaluated 80 countries using 20 quantitative and qualitative indicators and identified 5 categories: palliative and healthcare environment, human resources, the affordability of care, the quality of care, the level of community engagement. And the UK scored first place out of 80 in 2010 and 2015, which all seemed quite impressive. But then I saw that India was 67th. So I started being a little bit puzzled because I'd heard about Pallium. Next slide, please. And then I remembered back to the COVID-19 pandemic in the UK and my experience here of working in a massive university teaching hospital in Wales, and what we witnessed, where institutionalised palliative care is being delivered usually pretty well on the world scale, but all of a sudden healthcare systems were hugely overwhelmed. Many were dying highly medicalised deaths, often treated actively to the last minute. Many were alone at the end of life with minimal human connection. Most patients were frightened and unprepared, and symptoms were very often poorly controlled, despite all the access to everything we might wish for. Clinical staff were busy, overworked, compassion fatigued. And many patients died on uncomfortable trolleys in A&E or in hospital chairs. Rushed communication from medical staff, giving patients very limited of this autonomy that's considered to be so important in high-income countries. And many were only able to communicate with their loved ones electronically. Family having no time to spend with their dying loved ones, so making it extremely difficult to grieve. So this so-called idealised UK palliative care delivery failed many at a time when so many people were suffering. Next slide. And so I had a little look at what Pallium had been doing in India and was so hugely impressed to see what compassionate communities can deliver despite being up against it. And so I looked again into the literature and I found a really good paper that's just been published in 2025 by S. Zaman in the BMJ, again, very well respected journal in the UK, that challenges some of the cultural assumptions about what a good death is and asks us to rethink the global frameworks that we're perhaps using, that maybe what the global north considers to be the ivory tower of palliative care and end-of-life care delivery with the focus on autonomy and preferences of the dying individual might be very ill-fitting to those in the global south where many, many, many people are suffering and dying, but who get it perhaps much more right in terms of the emphasis being on the perspectives of those around them, their family caregivers and their social networks. So this was all getting me thinking quite a lot. So I looked into the literature some more. What constitutes a good death around the world? And thus the literature is much more thin when you look at the low to middle income countries, but there is some stuff out there if you look really hard. In Korea, preparation for dying is considered very important, as are family interactions, avoiding meaningless extension of life, ensuring dignity and comfort. In Bangladesh, the most important thing is the presence of loved ones. In Sri Lanka, it's very important for a person to not be aware of death, challenging to the autonomous UK model. In India, sometimes secrecy around a terminal diagnosis is considered a loving strategy. And in Taiwan, continuing a relationship with the deceased after death is of high importance. In Thailand, getting somebody home to die isn't because they can have that lovely sense of feeling in that comfortable French-style bed. Instead, it's about the fact that that relates for this group of people as a good rebirth, an opportunity for the best rebirth. So then I thought maybe I needed to look at things from a slightly different angle. Maybe I needed to look instead at what makes a poor death. And we've been in the UK, we have a new post that's been emerging called the Medical Examiner post, which actually has started to look at what end of life actually is and audit it better. And so I thought, well, this might be something that we could use to audit. So what are the factors that cause a poor death? Could this be something we could be more unified about universally across the world? Basic human needs not being met, a patient being able to eat or drink or be toileted or be clean or have dignity. Compassion, uncontrolled pain or symptoms. Patient being alone without family or people who care. Lack of resources, medication. Ironically, in this country, even with the huge amount of medication available, people don't always get what they need. But clearly in India, that is on a totally different order. Patient feeling psychologically distressed. Limited honest communication to support decision-making when it's wanted, whether that's to family or to the patient. Carers being isolated and overwhelmed, unsupported or restricted in access, that's universal. Or the environment not being safe, comfortable or peaceful. That could be ED in the UK, whereas it could be, you know, a back street in India, I would imagine. Over-medicalisation, you know, that can happen worldwide, even if access to healthcare is very disparate in low middle income countries. It's a big problem here in the UK. Reversible factors not being considered or addressed. Financial hardship, that happens here as well. Inadequate planning or plans not put into action. So then I tried to think, well, which things are mainly of the developing world or versus the developed world? Is it that in high income countries, it's all about over medicalization, focus on cure, meaningless prolongation of life, the preference for autonomous choice that doesn't always happen, fragmented family social support structures. We've lost that structure that low and middle income countries really have as a strength quite often. The limited acceptance of death, the fact that we in the West have this massive illusion about what life can be and what death also can be. And the fact that in healthcare and in palliative care in the UK, sometimes this high value being put on accepting dying, is that really right for every person? Versus perhaps in the developing world, you know, the financial burdens of treatment, as we've been hearing about in the first presentation, that people don't always have any money to pay for treatment, or the option to stop working when they need to support their family just makes accessing healthcare impossible. Maybe some families prefer, the preference for medical teams to be making decisions or family to lead decision making. There might be limited access to medication or other resources, or a limited access to specialist palliative care expertise. High rates of suicide in the terminally ill, limited emotional support for patients and loved ones. But when you look at these things, it's hard to know that it's all happening in one area of the world or all happening in another area of the world. There's a lot of overlap, in fact. Back to my friend, my learned psychologist friend, and I said, tell me again, what do you think is a good death? He said, somewhere I feel psychologically safe, somewhere I feel physically safe, where I have choice when I want to have choice, to be in a nice environment and have as little pain as possible. So we decided she'd better move in and live with me. So case examples. In the UK, we're very lucky, we're very privileged to have the healthcare system that we have, and to have palliative care as developed as it is. But just to exemplify from some cases that I've come across in my career in palliative care, Mr. W, a 69-year-old man who I looked after in a hospice in Wales in 2015, was in the last stages of pancreatic cancer. At the end of his life, despite being in pain and having as much pain relief readily available if he chose to have it, he chose to die with no pain relief. It turned out that this man was actually someone who had been very involved in the illicit drug industry, shall we say. And he was very afraid, ironically, of pain relief. So he died in incredible pain. Mr. Lee was a 78-year-old Chinese man that I looked after in the University Hospital of Wales, who was dying of renal failure. The hospital team here tried again and again to talk to Mr. Lee, but he deferred decision-making to his sons every time. And I was asked to go and see this gentleman because the team was so frustrated that they weren't offering him the idealized end of life opportunity, and that perhaps he didn't understand, or that they weren't communicating adequately. His sons wouldn't allow discontinuation of his energy feeding, and the ward were extremely distressed by this. They felt it was prolonging the chap's suffering. So I talked to his son, and they said to me, we come from China. We know he's dying. He knows he's dying. But we need to honour him by making sure that he has everything and try to prolong his life right until the end. This is Janket. She was a 32-year-old woman, a Czech woman I looked after in a hospice. She'd been in Wales since she was 25. She was married to a Welsh man. She had 2 young children. She was dying of metastatic cervical cancer in the hospice that I was working with at the time. She again refused to discuss her situation and accept that she was dying right up until the last day of her life. And afterwards, her husband said to me, she knew she was dying. She just didn't want to talk about it. She wanted her children to believe that she wanted to remain here to be their mother, and that she was not giving up right until the end. And then only a few months ago, Mr. Allen, an 84-year-old man with end-stage COPD, came into the hospital here. He had come in with breathlessness, he had a chest infection, and he had been told that he was end of life. He lived alone, he had no family, he'd always lived alone. He chose to self-discharge after hearing this news before any arrangements could be made to support him. He wanted to die alone as he'd lived, alone. So even with all this on offer for brilliant palliative care, people still want the right to make a choice. So I carried on my research, and I found that if I Googled a good death, I came across a film. And that this film was actually about Janet, who was terminally ill, who wanted to die in a dignified way, but British laws wouldn't allow it. That she wanted to, didn't want to die in unbearable pain, and that she was making arrangements to go to Switzerland for euthanasia. Going back to that Lancet meta-systematic review and the 11 conditions, the one that I'd missed right at the bottom, the right to terminate one's own life as a means to escape or abandon the medicalised dying process or to control one's own fate. As a palliative care physician for nearly 30 years, that's shocking to me, that should be the 11th condition, that people want the right to choose to terminate their life. So is ending one's life a choice born of desire for control, or is it for the avoidance of suffering? In the UK, we're facing the possibility of assisted dying legislation being accepted. In India, 1 in 5 suicides are committed by someone with an advanced life-limiting condition because they don't want to continue in pain, or because they can't afford treatment, or they don't want to put their family into financial destitution. Yet across the world, many consider access to palliative care as synonymous with a good death, through the reduction of the wish for euthanasia or suicide. Yet there remains a huge disparity of palliative care access even in the UK, especially on the basis of diagnosis, but for lots of other reasons also. And less than 2% of the population in India are ever lucky enough to receive palliative care, although we can see that Pallium are doing everything they can to change that. So what would the dying say matters most to them if they could return and tell us? Would they say dignity, honesty, respect, compassion, connection, our time? All of these things can be provided by anyone involved in the care of someone who is dying, regardless of what country in the world they might be in. So within the bed race game, we've included questions that exemplify this. For example, a hospital cleaner noticing a 90-year-old lady is gradually getting weaker and seeming to be dying. The question is, what could you do to help this lady to have a better end of life? And the options are: talk gently and kindly, explaining who you are, complete your work quickly and quietly, let a nurse know if you think she has pain, make sure her call bell is in reach, or all of these. And of course, E is the correct answer. All of these might help, and anyone working in healthcare has an important role to play in the care of patients at the end of life, because compassion and respectful behaviour can make a difference to a patient, any patient, at this incredibly important time. So what do I think? I think in the end, it appears to me that a good death is a totally individual decision, influenced by many factors and including the choices available to us, depending on where we live or whatever our life has been. But at its core, it's the wish to avoid suffering in all its many different forms. So then I asked my partner, because in this cosmopolitan world, I thought, well, it's not just where you live in what country. He has an Indian heritage. He lived in Africa for a lot of his childhood and then moved to the UK. So he's quite a cosmopolitan person. And I said to him, what would be a good death for you? And he said, just holding your hand as I die.
Thank you, Claire. A very thoughtful and deep look at what makes a good death. So it's a great pleasure that invite our final speaker, Dr. Dylan Harris. Dylan is a consultant in palliative medicine in South Wales with the NHS and Hospice of the Valleys, and a lecturer at Cardiff University. He has a specific interest in teaching and education around palliative and end-of-life care, and he'll be reflecting on the potential role of games in palliative and end-of-life care education in this session today.
So I think it's afternoon or evening for some people, and morning and lunchtime for others. And thank you for the invite. So it's an interesting question I was asked to try and tackle about games, and are they an appropriate and effective method for teaching palliative care? If you just go to the next slide. And so what I was thinking about in my own mind was 3 questions really, and flipping back and forth between these 3 questions, and I'll reflect on a few things with you. And to answer the bottom question, which was the one I was asked about, we sort of need to think about the 2 that come before it. So what makes a good game? What makes a good educational game? And what could make a good palliative and end-of-life care educational game? So a good game just needs to be fun and interesting and something you want to play again. An educational game obviously needs to work, as in some valuable learning coming from it. And if you click next again, so for a palliative care education game. Is it appropriate? Palliative care is a very serious topic. Should we be using games? What do learners think about using games to teach in this way? And I'll give you a few short examples, and then going to use a board game then as an example to pick up some of the points we come to with the first two questions, and leave you with 5 top tips at the end. If I've hooked you into using games in your teaching, 5 top tips to take away. Okay, next slide, please. So if you came around to our house at home, we've got 2 shelves full of games, and these are some of the ones that you'd find. Some of them you'd probably recognise, and you may have played or may have at home. And my favourite of all of those is Genius Square, and it's my 8-year-old daughter, who's the youngest person in our house, who's actually the best and quickest, and she's the one to beat at home. Next slide, please. So if you just think about any board game, card game, trivia game, puzzle game, and just hold in your head what your favourite one is, or your favourite 2 games, and think about why. What is it about that game that's just made you put it as your favourite? So card game, board game, trivia game, puzzle game, anything like that. What is it about it? And hold that in your head a second. So keep those thoughts. We're just going to tidy up a few definitions as we go through. So if we go to the next slide, please. So as we're thinking through games, we might see some words come up, and in some of the papers that I'll mention, you'll see things in the title of the paper, and it's just helpful to know what they're talking about. So games in education, you'll find lots of different definitions. This is one definition here, but we get the gist. It's something that's used as a method that the learner has to actively participate in, usually in a competitive way, not necessarily with other people, and there's some sort of preset rules for learning. Okay, next. And then we might see these 2 terms, so gamification and game-based learning. So gamification is putting elements of games into your teaching. So you may have quizzes, or you're using a crossword in your handout, or you've put people into groups to do something and you're giving a prize. So game sort of elements. And then game-based learning, we're going to use a game itself to entirely deliver whatever the learning outcomes are of those sessions. And then next, on the bottom, is serious games. So that doesn't mean you have to be very serious when you're playing them. It just means that the games have got a more serious intent, like healthcare, education, beyond the sort of fun of playing them. But there's a little caution sign with all of these. So you'll read some papers, and they may have in the heading gamification, and if you actually read the paper, what they're talking about probably is more game-based learning and vice versa. So that's usually what these terms are meant to mean, but you will see some variation. Okay, next. And if you click again, Melvin. So what people have tried to do is look at successful commercial games. That would be the games that you've got in your head, and for me that was Genius Square. And they've looked at successful educational games, both in the sort of research that's come from them and what things people buy or go back to. And there are a few different versions of this sort of a taxonomy. I like this one because it's quite visual. You'll see other sort of versions of a very similar thing. And what they've done here is split down some key elements of successful games into these color zones, or they've given each zone a different name. And what we'd probably find if we were in a smaller group and asked you each to tell me about what the game was that you picked and why, we'd find that most of those games have got multiple elements that are in this taxonomy, and probably the ones that would most commonly come up in our list have probably got things in all of these color zones. So I'm not going to go through each of those, but I'll give you the reference to this at the end, but just pick up on a few examples. So that the top right there, what they call ecological things. So having something that brings in randomness, luck, or chance, so often rolling a dice, can balance out things in a game. So if you've got somebody that's particularly good, particularly in an educational game, and others less so, having a dice, it brings in an element of chance, can help level things out. Often games may have some sort of transaction in them, so Monopoly, where you're exchanging money, and games may have a time pressure. We've probably all played, we used to play Monopoly when I was a child at home. It went on for days, we all sort of lost the will to live and didn't really care who won by the end of it. So having time pressure in games can help to make sure there's an end point and somebody actually wins the games. Then the next sort of bottom right there, so there's social aspects. So lots of games will either have cooperation or competition or both. So either you're playing against other players or you've got to work with other players to do something, or in some games you'll need to do both. You're playing against other teams, but you're working with someone in your team. Then into the sort of green zone, so personal attraction, something that's novelty, a bit different about this game or approaching this teaching topic in this way, but at the same time, really important that the game has got a really clear objective or mission as to what you're trying to do. So it's really clear what the purpose is. Fictional elements, a lot of games will involve fictional characters or a fictional story. So in educational games, we can use a patient story then to give lots more meaning and context. And then the top left sort of purple segment, winning or trying to get something or achieving something through performance in the game, so badges, trophies, levels, those sort of things. So if you think back to whatever you picked as your favorite game and why, I suspect most of what people had would have multiple of these elements and probably elements in all of those color zones. Thank you, Melvin. Just go on to the next one. And if we think about what you have to do in a game and think about what we're trying to achieve when we're teaching beyond the actual teaching topic, there's lots of things that you're doing in a game that actually overlap quite well with education. So actively learning things, trying to solve problems, doing it in a very risk-free way. It's only a game, having to use analytical skills, multitasking, team working, and talking to other players and interacting with other people. So all of those things we're trying to do through our teaching anyway, and often you do them in a game. But we have to be really, really careful that a game doesn't become too gimmicky and then a complete distraction to what we're actually trying to teach or learn about. Games can have facilitators in them, so you'd have a faculty member facilitating the game, or you could design something or have a task or something that people could do by themselves without someone in the room with them. So if we're going to use a facilitated game and it's a game with a very small number of players, we're just going to think we're going to need a lot of facilitators if we've got a large group of learners. The evidence base is a bit tricky around games, and we'll see why. People have tried, but some of the difficulties around it. And I don't think anyone anywhere is saying games are a panacea for all learning. They've got a place, as has every other type of teaching method. Thank you. Just the next slide, please. So there's quite a lot of evidence about games in general in healthcare education, and I can give you some of these at the end if you wanted to look more into them, and you'll find quite a lot of systematic reviews. Next slide, please. And what they've used all sorts of groups of learners, so just examples on the left hand side, and all sorts of topics, things you think you wouldn't be able to turn into a game, people have managed to do on the right hand side. Next slide, please. And generally what they've found is if you've carefully selected what you're using games for, it's least as effective as controls or as in a traditional learning, or a lot of the time more effective for improving knowledge, skills, attitudes, and the learner's satisfaction. So just one example of the sort of thing you'd see in those systematic reviews. So I wouldn't worry too much about the detail, but you can see a line with a 0 on it. Essentially, they're looking at people's learning from using teaching techniques with games involved versus ones that didn't, or traditional teaching, often sort of a lecture type format. And if the little green median and standard deviation is more to the right of that 0, it's favouring more the sort of game learning, and if it's more to the left, the sort of traditional methods. And you can see an impression that it's favouring more to the right here. With those studies, some of them can be quite small sample sizes. Often different studies have evaluated the games in quite different ways, so it's quite hard then for a systematic reviewer to put all of these things together. There's not always a comparator, so comparator to another teaching technique. And the tricky thing is, if you set up a study and you're going to randomize half your people into this room with use of games in teaching, and half of people into that room that are going to get a lecture. If you're randomized into the room when you're playing a game, you clearly know that you've been randomized into that half of the study. So I think we're sympathetic to why people have sometimes found it difficult and why there's some limitations in the literature. The next slide, please. But what we're aiming to do if we're using games is the same as with any teaching that we're doing. And many of you will have seen Miller's pyramid before, so sort of a hierarchy of, I guess, what we're trying to achieve with any healthcare education. So the bottom level is knowing, and that's just knowing a recall of facts. So we want to get much more beyond that, but we do need that baseline knowledge of some core material and facts. We want people to be able to then use that material they've learned and show how they can interpret and apply it in different scenarios and settings, demonstrate how they could do that sometimes in a controlled way, and then the top of that pyramid is actually then go and use that then in their own clinical practice. And that's how we'd be thinking about games the same way as any teaching session when we're trying to set them up. So how can we use the game to help things that would actually the learner would then be able to do or use in their clinical practice. Next slide. So you'll have a toolbox like this when you're teaching palliative care to other people. So you might use bedside teaching, recorded videos, etc. But is games something to add into the toolbox that you already use? Next slide, please. So we can apply those principles in palliative and end-of-life care. If you look in those systematic reviews that I was showing earlier, there isn't very much at all about games in palliative and end-of-life care in what people have published. You can find a few published examples, so I've given a few in a list here. So escape rooms, I've seen published examples, and we use one ourselves on our MSc course in Cardiff. So essentially, we lock a group of learners in a room with a padlock. The padlock needs a number of letters to get back out of the room, and in the room they'll find a number of tasks and puzzles. In this case, they're around managing symptoms in palliative care, so it might be a puzzle around a breathless patient with things that they could use to help their breathlessness. Depending on what they pick, we'll give them a different letter, and they can try and put that into the lock to get back out of the room. Another colleague uses coloured pipe cleaners, and so that's used in part of her teaching session around pain and palliative care. So she puts people into groups, and they all get a load of coloured pipe cleaners and other bits and pieces, and they try and then connect up, make that into a picture of a pain pathway. So that's using more sort of gamification. Card games, they'll see some examples of those, and some examples of those used with patients, particularly around advanced care planning, to help them think what priorities might be for them and what things they may wish to have or may wish not to have. So that's been used with professionals and some with patients. And then virtual learning environments, you might have, that would be an online based game. So one example is a sort of street with some patients that live on that street who've got various life limiting progressive illness. And as you click through things on that platform, their sort of story evolves as they approach the end of life, and you get asked choices of things to do. And then the bottom example is a board game. So I was going to use this example to try and go back to the two questions we were thinking about earlier to see, can we apply this in palliative care? Thank you, Melvin. Just next slide. So this is a board game, so you can see it's got a start at the bottom and a finish at the top. So this is called Bed Race. So it can be played with 4 players or 4 teams of players. And if you click the next button, Melvin, they're trying to get from the start to the finish line. And this is somebody's palliative and end-of-life journey. So they've each got a little coloured bed, which you can see there, but they need to collect some things along that journey to get to the finish. So the things that they're trying to collect, so just in case, anticipatory medicine for end of life care, a DNAR, so do not resuscitate form, a heart which is there to represent communication and compassion, a syringe driver, a candle which is there for spiritual care, and some oral balance gel, and that's there to think about attention to detail in managing symptoms. So they're going to roll a dice, but every time they get to the little squares that look like a target on them, they can try and pick up one of those items, but they're going to have to answer a quiz question to pick those up. So within their team, they can try and answer the question. I'll show you an example of those in a second. And normally when we play this at the end, we'll put something. So normally I call in the supermarket and buy a box of chocolates or big boxes of sweets. So the winning team not only get to the end, but they'll win something at the end. But they're trying to get there the quickest, but pick up all of those items on the way. Next slide, please. So when they get to those target points, they're going to have to answer in their team a question about a patient. So the questions are all clinically related, so they're not things about pain receptors or pain pathways. So there's an example of one here. So you need to have some knowledge and then be able to apply it to answer the question. So you can see the questions are all color coded, and they've got a number on them. It's probably quite small to see on the screen. So what that means is if I was doing something with a group of learners and I wanted a completely random set of questions, I can just take the whole pile and shuffle them, and we'll see what ones come up. If there were particular things I wanted to cover with a particular group of learners, from using the color code on the back of the card, I could pick out certain questions and then shuffle those in the ones that are on the game board. To get the heart, which is for the compassion and the communication, that's slightly different. So you can see it's a multiple choice style question. For the other ones, the communication card is a very short description about a patient, and the card always ends in a question from the patient or from one of their carers and relatives. And so what the team need to do here is come up with 3 to 4 strategies, top tips, or useful phrases that they could use to help answer those questions. Again, we can go through the pile beforehand, depending on what the group of learners we were playing with. And some of these are harder, they're more difficult questions that we all find difficult to answer, and some are more straightforward. So we can shuffle and select what cards are there. Next slide, please. I think we've gone back, have we? Sorry, no, we haven't gone back. So coming back to that taxonomy, that was that coloured picture at the beginning, and we can start to see then we can use elements of that in a game like this here. So we've got a clear mission and an objective. So if you can click again, I can't quite remember what the other bubbles were. So how we played this game, so normally the learners are in groups in 4 little teams, and they're playing against the other teams on the game board. So we're going to use cooperation and competition. They're trying to collect all those things as they go around the board. So we've got the badges and trophies. Click again. We've got the dice, so if we happen to have one team that was much more knowledgeable and able than the other, because we're using elements of chance or rolling a dice, that can help balance this out, so it's not a sort of a one-man race to the end. And all of the questions that we use are about real patients, real things that group of learners could come across in their day-to-day practice. So there's sort of meaning and context, rather than sort of focusing on theoretical things like pain receptors and pain pathways. Thank you. Next slide, please. So what do learners think about it? If they're coming and thinking they're getting a lecture and now they're playing a game. So the original version of this game we used with final year medical students, and we collected quite a lot of data with the first 600 that we played it with, and it's now been played with, I think, over 1,500. So a couple of examples of the sort of things we looked at here. So the graph you can see here, so those groups actually did, we called it a quiz, but it was sort of a test of their applied knowledge before and after playing the game around certain topics that we'd put in the game to come up. And the orange bars are their sort of scores after, and the blue bars are their knowledge before. So their blue bars are quite high because they're final year medical students, and you can sort of see the orange ones are higher, and that was statistically significant. And we did something similar with them rating their own confidence. And then we asked them a few free text questions as well. So it's a lot of free text because of the number of them. And we put that all into a database and used a thematic analysis approach to pull out what the themes were. And there were 3 big themes that came back from them with the original version of the game. So they did find it fun, which is good. But remember, if it's an educational game, we're looking for something a bit more than that. But they did feel it was very relevant and useful learning that they were actually getting whilst having fun playing the game. And they really liked having the teamwork and having to work together in little teams, which is what we do every day, isn't it, in our clinical practice, to try and work out how they'd approach that communication question or how they'd answer it. So then people asked us, well, this looks good. Could we use it with other groups of learners? We originally were using it with medical students. So we re-looked at all of the questions. We had a group of a number of other professional colleagues who helped us, so psychology, physiotherapy, dietitian, chaplaincy service. So we added more questions and reviewed and altered some of the existed ones, and then used the game with multi-professional learners playing it in an interprofessional way. If you go to the next slide, please. So similarly, we collected a load of data with them. So a couple of examples. So this is now, these are multi-professional learners playing this game together in teams. And in this graph here, they're scoring whether they felt learning in this way facilitated or promoted things like constructive learning, interaction with colleagues, and developing their knowledge and understanding about palliative and end-of-life care. And similarly, we asked them a lot of free text questions as well. Interestingly, it's quite similar to what the medical students have said. So the word fun comes out a lot, useful learning, but the comment on the bottom now is then more into that top of that pyramid that we were looking for with Miller's pyramid. So they were able to give quite good examples of things they were now going to go away and think differently about or do differently. Not just things with patients, but different ways of working with other colleagues that are on their ward or in their team, having played this game and had to do things together. Next slide, please. So back to our 3 questions. So we thought about our favourite game. We thought a little bit about educational games and some of the evidence around them. And then we were thinking, could this apply to palliative care? So there's not a huge evidence base of games in palliative care, but it does seem appropriate. Learners find it an appropriate and relevant way to help with their learning. That fun word comes across a lot, and it seems to help them with things they can then use in their clinical practice. So next slide, please. So I said I'd leave you then at the end with 5 top tips. So any use of games, just 5 top tips to take away. Important one, number 1, start with the end in mind. If you could just click again for me, and never lose sight of it. Who are you teaching and why, and what are you aiming to teach them? So we can get a bit carried away with gimmicks and gadgets. So we're always going to come back to who are we teaching and why, what are we aiming to teach them, and make sure we don't lose sight of that. We can use that gaming taxonomy that I showed you, and I'll give you a link to at the end. And we know that the most successful games will have a number of those elements in them. So when we're thinking about how we're going to use them, we can use that. As with any teaching session, preparation is really important. So if we're going to put people into teams to do things, how are we going to split them up? How are we going to set the room up? And how are we going to keep things to time? And in any game, you want to get to somebody that's clearly a winner. So how are we going to use timed answers or a facilitator to keep things to time? Are we going to use a facilitator with the game so they can correct things, help people as they go along? Or are we going to design something that players could play on their own, and that frees a facilitator to use something else? So the board game that I was just showing you can be used either way, because the answers are in the game, or you can use it with a facilitator as well. Number 4, so start with a safe learning environment. If people are turning up thinking they're going to get a lecture, and now we're putting them into teams and we're saying we're going to play a game, we just need to be clear that everyone's really happy and comfortable with that at the beginning, and that they feel it's really safe. So it is only a game. There's nothing in there that's a test, and it's a very safe space to explore learning. And having people in teams rather than playing individually can help with that, with the pressure. Your game would probably have some sort of question or puzzle in it, so think about the format. So we asked all of those medical students originally, and they were very, very keen that we gave the questions in that best of 5 format, like the example that I showed you, so 5 possible answers, because that's how they get asked things and tested in their exams. So other groups of learners, you might do something quite different. If you put answers on the card and they're picking from them, that's slightly less pressure than an open question that they've got an answer to. Make it real, make it about patient stories, things that they can relate to, and try and quiz more than facts. So thinking of puzzles or things that test more than that bottom layer of Miller's pyramids, applying facts or trying to demonstrate. And then when you've done all that, go back to that first point and don't lose sight of it. So who are we teaching and why, and what was it that we were aiming to teach them, to make sure that we've not got too carried away with our game. Always come back to that. And last slide, please, Melvin. So these are some of the references that are on the other slides. If you wanted to read more about the board game I was showing you, that's that paper there. And the one, the Toda et al. Paper at the bottom is where that really useful taxonomy picture came from, if you wanted to look at that one. Thank you, Melvin.
Lovely. Thank you, Dylan. Well, you know, games are close to my heart, and I appreciate what you've been saying through there, and absolutely agree with that approach and your analysis. And just leaves me to thank all of our speakers today. Really appreciate you taking the time. Very insightful and very informative. Just to remind all the delegates that there will be a recording of this, which you will get a link to following the close of the presentation, and also we will post it on our social channel as well, so that it can be shared a little bit wider. When the conference finishes, you will get an email which allows you to provide any feedback, and also those who wish a certificate of participation can get that through the same link as well. It's an automatic system for those who have attended the conference, the webinar. Just be aware that whatever you type in the namespace is what will appear on your certificate. So just consider that what you want to appear on your certificate. I'll close there, and I'll thank everyone. I'll thank our speakers once again, and all of our participants taking the time. We had representatives from over 12 countries participating today, so really appreciate it. And we will look forward to future webinars, and we'll keep you up to date. Thanks, everyone. Appreciate it.